Salam alaikum, everyone. Apologies for the delay. We're going to get going in a minute. I'm just letting people's audio connections just establish, and then we will get going. Great. Okay. I think we'll get going, Rafida.
Okay.
So, Salam alaikum, everyone. Good evening. Thanks for joining us. This is the last of certainly the last of the Irish College of General Practitioners webinars for 2021. We're delighted that you're able to join us this evening. It's my great pleasure to introduce Dr. Harry Barry, who is a family medicine doctor from Drogheda, one of the big cities in Ireland. And Dr. Harry is here to talk this evening about somatization and how that can arise associated with anxiety and depression. Dr. Harry Barry is a international best-selling author in this area. He's as I said, a family doctor with a special interest in mental health. This evening, you're all on mute to begin with, but if you wish, when we get to the end, if you want to store up your questions for Dr. Barry, and you can turn on your audio and your camera if you wish to speak up yourself or relay your questions in the chat. And we hopefully will speak for about 45 minutes and then have about 20 or 30 minutes for the Q&A. So without further ado, I'll hand over to Dr. Harry Barry.
Thanks very much, Brian, and welcome to everybody. This evening, we're going to talk about really the neuroscience between the mind, the brain, and the body, which underlies so much of the physical symptoms you see in everyday primary care. We're going to have a serious look at the world of anxiety, and we're going to focus very much on the physical nature of anxiety and also the world of depression. And then I'm going to teach you some very simple CBT, what we call cognitive behavior method techniques, how to assist you to manage these conditions. So that's our plan for today. So we're going to start with the neuroscience. So I think the first thing is that family doctors are really well used to the whole world of physical illness, to the world of diabetes, heart disease, etc., etc. But I think there's less of an understanding of the importance of how much work the family doctor will actually end up being involved in the whole area of somatic symptoms. And these are very much connected to stress and anxiety and depression. So we're going to very much go through those. So the first thing I want to talk about is the unconscious versus the conscious processes in the body. And I think it's really important that all of us, our bodies are quite extraordinary. Our brain is controlling all these amazing automatic things like our heart rate, our respiratory rate, our temperature. So many parts of our body are controlled unconsciously, and so much of what happens in our bodies occurs unconsciously. But there's also a certain percentage of our brain is very much involved in consciously thinking things through. So the difficulty we have is that we don't understand a lot of the time the links between our brain and our body. And therefore, when unconscious automatic symptoms start to appear in our conscious mind, we become really, really distressed by them. And we're going to very much deal with that this evening. So at the heart of anxiety is the world of neuroplasticity. So I just want to quickly talk about, because I'm going to try and give you a little insight into the world of neuroscience. And the most important thing from a neuroplastic point of view is your brain is composed of absolutely trillions of connections, billions of neurons and trillions of connections. And all of these are changing constantly all the time. So that you don't realize, but by the end of this talk, your brain will not be quite the same as it was before, because you'll have learned new information, new pathways have been formed in your brain, and that this is going on continuously every moment of the day. So the real secret to anxiety is that when we're kind of younger, we often pick up anxiety pathways, or they're often set down when we're coming through our families and our upbringing. So often by adulthood, we have developed anxiety type pathways. So neuroplasticity is wonderful though, because neuroplasticity says the three rules are use it or lose it. The second one is neurons that wire together, fire together. And the third one is that neurons fire apart, wire apart. What that means in practice is that if I use something regularly, it becomes stronger. And if I use it less regularly, it becomes weaker. So what we need to do is teach you, how can I use simple techniques to weaken the somatic symptoms of anxiety? So let's now talk about the whole world of neuroscience. So I'm going to start by the world of the amygdala. So really, really important that we all have a rational brain, which is our cortex, particularly our prefrontal cortex here. And we have an emotional brain, which is in the very center of the brain here. And in the middle of that is a tiny little organ on the amygdala, which we have on either side of the brain. And this little organ is absolutely vital to us. It's the key to so much of our difficulties with anxiety and depression and stress. So the amygdala is situated in the heart of the emotional brain, and it's there from the time of the dinosaur, and its job is to look for danger internally in our heads or externally in the environment. And if it senses danger, what it does is send information down through the sympathetic nervous system and the bloodstream to our adrenal gland. And our adrenal gland is our stress gland. So if we're acutely stressed or fearful, we release our fear hormone, adrenaline. If we're chronically stressed, we release our chronic stress hormone, glucocortisol. And these key hormones are absolutely vital to all of the somatic symptoms which many of us experience, things like tension headaches and irritable bowel and so many conditions that we'll be talking about as we go along. So it's really important to understand the world of the amygdala. So what is the function of the amygdala? Well, the function of the amygdala is to look for danger, release adrenaline. If the amygdala feels you have to fight, it'll get you to release noradrenaline, your aggression hormone, but in general, it'll get you to release adrenaline, your fear hormone. So the secret to panic attacks, which we'll be talking about later, is that panic attacks are simply somatic symptoms, physical symptoms created by a huge burst of adrenaline in your body. And you're going to see these constantly throughout your whole lifetime as family doctors. So it's really, really important that you understand what they are and how you manage them. The second key player is glucocortisol, and that's your chronic stress hormone. And it's the guy that when you're very stressed or generally very anxious, that gives you the symptoms like tiredness, wired, sleep difficulties, nightmares, teeth grinding, fatigue, tired but wired. So many symptoms that we're all experiencing at the moment as a result of, say, the pandemic. So when we're acutely panicky or fearful, we release adrenaline. And when we're chronically stressed or anxious, we release glucocortisol. So it's really important that we understand that these are the hormones that are going to control so many of the physical symptoms that we're actually going to see in real life. The third part of the chain of the neuroscience is really the prefrontal cortex. So going back again to our little diagram here, that's this area really just situated there. And our right prefrontal cortex is where we catastrophize. That's where we visualize all the time the worst case scenario. The left side is where we actually ruminate and worry. And it's very, very important in depression. So this is really important in anxiety, and this is possibly more important in depression. So to give you an idea though of how your stress system works, and this will be of great relevance to when we go to discuss panic attacks. Many years ago in the developing world, I remember coming across a leopard at 3 in the morning. So before I registered there was a leopard there, my amygdala already picked out the leopard and fired. So suddenly I froze, and then I was shaking and sweating and stomach and knots and heart pounding and shaking and sweating and all these physical symptoms, muscles tense, mouth dry. And then I registered there was a leopard. So the first thing was that the amygdala gets the information first before the rational brain gets it. So it got me to freeze and then got me to prepare to run by pumping in adrenaline, because all that adrenaline does, it prepares me to run. If my heart goes faster, I'll run quicker. If my breathing faster, I'll run quicker. If I'm sweating, I will run quicker. If my mouth goes dry, all the blood is taken and sent to my muscles. So it's all about preparing me to run, not getting me to run, preparing me to run. So the amygdala wouldn't let me move till the leopard went about 10 or 15 yards. And then I ran back to the house. Then 15 minutes later, everything went back to normal. Why? Because the danger was gone. And that's the secret to the whole stress system, that the amygdala is set up to keep me safe, to look after me. So now we're going to move on. That's the neuroscience behind anxiety. So I'm just going to talk about when people come into you and they say that I am anxious, it's really important that you just don't accept their word anxiety, because there are 3 types of anxiety. And I'm trying to teach all family doctors that there are 3 kinds of anxiety. The first type of anxiety is acute anxiety. And this is an intensely physical, visceral type of anxiety. And there are 2 common forms, panic attacks and phobias. So let's just describe what these are. A panic attack is where out of nowhere, you suddenly get this incredible burst of adrenaline where you get shaking and sweating and heart pounding, racing, can't breathe properly, sweating, dry mouth, and a terrible sense of dread that something terrible is going to happen. And this can go on for up to 5 to 10 minutes. And if you try to stop it, it can go on for up to an hour. It's terrifying. There's no obvious reason for it. And the person then develops a thing called panic disorder, where they become increasingly terrified that they're going to get another panic attack. So the fear of getting a panic attack becomes as big, as major as the panic attack itself. The second part is a phobia, and a phobia is an irrational fear that I assign to some particular situation or person or object. So, for example, I might have a phobia about getting on a plane, getting on a bus, getting in a car, driving in a motorway, going into a crowd, leaving the house, going into a lift. So all that happens in a phobia is I get the same visceral physical reactions I get in a panic attack the minute I'm exposed to whatever I'm afraid of. And it's absolutely paralyzing for people's lives. So that's acute anxiety, very visceral, very physical. The second type of anxiety is called general anxiety. And this is the one that particularly you will see an awful lot in females, because they're particularly prone to this, but also both sexes will get this. And this is where we get this mixture of cognitive and physical symptoms. So the cognitive symptoms are this terrible sense of foreboding, constantly worrying, all the time catastrophizing about what might happen in the future. It's very much associated with cognitive difficulties and these low-grade fatigue, irritable bowel, being wired all the time, nightmares, teeth grinding, and very uncomfortable physical symptoms. The third type of anxiety is called social anxiety, and there are 2 main forms. Social interaction anxiety, that's where I get very anxious when I go into a group of people where I think that they're going to start judging me. And we'll be talking about this later. And then social performance anxiety is where I have to present something to people, and this can be paralyzing for some people. So these, I think it's really important that we get the person to try and put their finger on what type of anxiety am I dealing with. Because they're all, if you notice with, they all have physical symptoms, and this is how they're going to present to you. So before I move on to dealing with those, I just want to talk very quickly about the world of CBT. Cognitive behavior therapy is a fantastic skill that all family doctors should have out there. Very simple ideas behind it. Now, to become a real serious CBT therapist can take up to 7 years. And you have to be highly trained. And I would actually have done a good bit of training in this. But I suggest a thing called cognitive behavior methods, which are hugely used in primary care and are very, very helpful for the family doctor. So it's based on the concept that your thoughts influence your emotions, which influence your behavior. So whatever you think influences whatever you feel, which influences what you do. And the second thing, it's not what happens to you in life that causes you distress. It's how you choose to interpret it. So those are the cardinal rules behind CBT. An unhealthy negative emotion is something like anxiety or depression. Then we all have these rational or irrational beliefs. Every solitary person listening to me, including myself, will either have rational beliefs or irrational beliefs. These are ways of thinking about the world which are either very healthy and helpful, or which are very unhealthy and unhelpful and lead to a lot of unhealthy negative emotions. And all of us have these ways of thinking about the world which are formed in our childhood and adolescence and early adult life. So all that we have to do in terms of general anxiety and social anxiety is discover what those irrational beliefs are and change them. And then we always challenge the person's behavior as well. So that's how CBT works, by changing your thinking and changing your behavior. That's it in a nutshell. Change how you think, it should change what you feel, and in turn, you also change your behavior. CBM is simply just very simple techniques that anybody can use. I teach these even to therapists, to nurses, to guidance counselors, and I've been trying to teach them here in Ireland to family doctors as well. So the simplest way to analyze a problem that you get in real life in family care is to analyze it using Ellis's ABC system. And Ellis was the father of CBT. He was the man who created CBT to start with. And he came up with this very simple way of breaking down a problem. And I use this constantly all the time. So it's an ABC system. The A is the activating event. In other words, what was the trigger? What was it that caused me to start feeling the way I feel to start with? And then my interpretation of that is, what is it about that trigger that causes me to feel the way I feel? The consequences of my emotion, which is, we'll see anxiety plus physical symptoms, and what do I do when I get anxious? And then underneath that is the B, or belief, which is my belief, irrational belief, which is driving so much of this. So let's take this as an example. Visualize that a student came into you and he has an upcoming exam, and he's complaining of being incredibly anxious. And he's physically, here we go again, he's exhausted. He's getting tension headaches. He's got irritable bowel. He's very tired. He's not sleeping well. And then the question, of course, you ask him then is, well, what is it about the upcoming exam that's causing you to feel so anxious? And of course, his interpretation is, maybe I'll do badly, won't get enough points. Maybe I'll fail to get the course I want, finish up doing something I don't want to do. And if all of this happens, I will feel a failure. So his demand is, I must do well in the exam. If not, I'm a failure. And that leads to him becoming very anxious. And that in turn leads him to overstudy or procrastinate, eating poorly, seeking reassurance, constantly worrying, constantly catastrophizing, and coming to you maybe with all the physical symptoms of the tension headaches and the fatigue and all the rest of it. So you can see that he's presenting really with physical symptoms, but their origin lies completely in this irrational belief that I must do well in my exams, if not, I'm a failure. So what CBT would get us to do, of course, is would get us to challenge the person's interpretation of the trigger or the irrational belief. So, for example, in this case, we could challenge the student's interpretation. How does he know for sure that he's going to fail his exam? Or would it be not better to challenge, in reality, his absolute demand that he must always do well in an exam, and if he isn't, he's a failure, and then challenge his behaviors? And that's what we would do in practice. So, in panic attacks and phobias, we always challenge the A, or their interpretation of the danger. And in social anxiety and general anxiety, we challenge the B. Don't worry if you feel a little bit overawed at this stage, because I'll show you how this works in practice as we go along. Okay, so now we're going to move to the panic attack. So the person comes into you and he's complaining of shaking and sweating and stomach knots and heart pounding. He's gone to the hospital. He's had all the cardiographs. He's been seen by the specialist, and he's been told that everything is going well. Okay, so he comes to you looking for some help, and the problem we have in family practice is that the doctor always gives the person medicines. So he gives them tranquilizers to which they become addicted, or he uses antidepressants, which make the matter worse. So you get them to do a simple ABC. And the trigger is, say, what is the first physical symptom you noticed when this panic attack started? And it would always be my heart going fast, shallow breathing, stomach knots, or whatever. And that's the trigger. The trigger is the first physical symptom they noticed. So the next question is, well, how did that make you feel? It made me feel panicky. And the next one is then, when you got panicky, what physical symptoms did you get? And I would read out these symptoms and ask them, which of these did you get? Shaking, sweating, palpitations, dry mouth, etc. So you write down which physical symptoms you got. And then what was it about the trigger that made you so panicky. And he felt, well, there are 4 dangers in a panic attack, and these are well worth having for the rest of your life. If you can remember the 4 key dangers in the panic attack, this will save you years of difficulties dealing with them. There are 4 dangers. The first one is a physical danger. I'm going to stop breathing, collapse, have a heart attack, have a stroke, and die. In other words, it's I'm going to die. Something terrible is going to happen physically, and I'm going to die. And that's the commonest danger. The second danger is I'm going to lose control and run amok and do something crazy. The third danger is people will see me. And the fourth danger is I'm going mad. So it'll always be one or all of those dangers. So my demand is the symptoms must stop. And then my behavior, unfortunately, is what do I do when I get panicky? I leave the area, go to A&E, went to the GP, tried to stop the physical symptoms. Somebody told me to use breathing exercise, which never worked. Tried to get help from loved ones, tried tranquilizers, and nothing worked. Because the more I tried these, the more panicky I became, and the more I got panicky that I would get another panic attack. So this can go on and eventually get to the stage where the person is really afraid to leave the house. They're so afraid of these panic attacks. So here's how you would use cognitive behavior methods. The first question is, well, you ask them what causes the physical symptoms? And they will tell you it's my emotional mind. But you tell them, no, they're caused by an adrenaline rush. And all an adrenaline rush is that the amygdala has sensed danger because you assigned a danger that something terrible is going to happen. It fired and it gave you a huge burst of adrenaline, which lasts for about 5 to 8 minutes. And I would explain to them the story of meeting the leopard. So in fact, all that happened was the amygdala was doing what it was trained to do. The trouble for the amygdala, he's not very smart. He's a long memory for danger. We call him the gunslinger because he fires instantly without thinking about it. And he doesn't do talk therapy. So you have this very visceral organ, the amygdala, that everybody's trying to treat cognitively when you can't treat it cognitively because he doesn't respond. So are these physical symptoms dangerous? Well, the answer is no. And really important as the doctor that you said, these physical symptoms are completely safe. They're purely your body's adrenaline firing. So if they don't believe you, will say, well, suppose I saw the leopard, survived the leopard, but dropped dead. Would that work? And of course, that wouldn't work. Suppose I was doing an exam and got got all of these adrenaline symptoms. Would I drop dead? Of course I wouldn't. Would I lose control? Of course I don't lose control because the amygdala will never let you lose control. And there's no question of going mad and people wouldn't see you because you can't see the physical symptoms of anxiety. So are the 4 dangers described actually true? And the answer is not. So it's really important that you dismantle their danger. But then you're left with one critical thing. Are these physical symptoms? Remember, this is all physical stuff. Are these physical symptoms uncomfortable? And of course they are. They're incredibly uncomfortable. So what actually most people are afraid of in both panic attacks and phobias is the actual discomfort of the physical symptoms. And that's where all the difficulties really occur. So you have to explain to me, yes, they are uncomfortable because they're meant to be uncomfortable because the amygdala is foolishly thinking that there is actually a danger when there isn't actually a danger at all. So all that a panic attack is the amygdala senses your danger because you got, do you remember the first physical symptom, which is your heart going fast, is just a simple sign of stress or excitement or anxiety. And all that happened was that you abnormalized that. And you then began to convince yourself that something terrible was going to happen. And so that's actually what happens in a panic attack. So are they uncomfortable? Yes, and you explain why. So then you go through to their behaviors. So do you think that leaving the area when you had a panic attack helped? And the answer, of course, is no. Do you think that using tranquilizers helped? The answer is no. Did breathing exercises? The answer is no. So all that happens is the more you try to stop these physical symptoms, the more you're saying to the amygdala, this is very dangerous, and the amygdala is not very smart. So what he does, he sends information down to your adrenal gland to pump in more adrenaline. And that's why these symptoms can go on for up to an hour. So the more you try to stop them, the more anxious the amygdala gets, and the more adrenaline you fire, and the thing goes on and on and on. And that's why all over the world, millions and millions and millions of people are suffering from this. Particularly in young people who look at a lot of social media, these are endemic. So you better get very good at managing these. So The answer then is, how long does an adrenaline rush actually last? And the reality, of course, is that if I did nothing, absolutely nothing, an adrenaline rush would last for 5 to 8 minutes. Because after a while, the amygdala realizes there's no danger and switches off. So the trouble is your behavior. So if we get you to stop running away and do something completely different, and I'm going to suggest to you something that has been sanctioned really by Professor Catherine Harmer, a professor of cognitive neuroscience in Oxford, who's a colleague, a friend of mine, and she absolutely supports this. And I'll give you the name of my book that she supports as well. So I suggest that you visualize you're stuck to the seat and use flooding. And flooding is an extraordinarily simple technique where you teach the person to go with the physical symptoms, to embrace the physical symptoms, to stop trying to push them away. The attitude should become, bring them on, let's have you. Do you know, in other words, go with them. And something extraordinary happens when you go with the physical symptoms of panic. The amygdala does 2 things. Firstly, it learns that you're no longer worried about them, so he switches off. And secondly, much more relevantly, he changes his memory, because the amygdala has the ability to down-regulate all these physical symptoms. So what it does, it down-regulates the physical symptoms so that the next time you get a panic episode, it's not so severe, and the next time it's not so severe, and very quickly you find the panic attack settle and clear. So I would get contacted. I have videos that I'll give you on my website, and I have videos that have been seen by people from all over the world, and I get contacted by many people thanking me. I've never seen them because this technique has got rid of their physical symptoms. So this is something you should learn and apply with your patients regularly, using the ABC, simple ABC, and teaching them flooding in the story. So what about a phobia? Well, a phobia is another very simple, visceral, somatic symptom of anxiety. So the person will come to you and say, you know, I get incredibly panicky if I have to go to school, if I have to get on the bus, if I have to go into a lift, if to go on a train, a bus, go on a motorway, go into a crowd. So here's a classic example of an ABC, of a phobia. The trigger is a young person going back to school after a break, very common in many, many countries. So they start to get incredibly panicky. So their interpretation is, what's the danger? So what is it about going to school that caused you to feel so panicky? And the answer will be, I feel trapped in the school. So whenever you hear the word trapped, you know that that person is really focusing in on the whole world of phobia. So, and what happens when you feel trapped? I'm going to get incredibly anxious, physically anxious. So what kind of symptoms will you get? I'm going to get shaking and sweating and palpitations and dry mouth. Sound very similar. Another burst of adrenaline happening here, very similar to a panic attack. So why are you worried about these physical symptoms? Again, the 4 dangers. One is I may become physically stop breathing or die. That's not as common, believe it or not, as I'm going to lose control and run amok. That's the big one in phobias. I'm going to do some, on the plane, I'm going to run up and down the plane and go crazy, or on the bus or on the train or in the lift. So people will see me then and I'll feel ashamed. So that's why phobias are so paralyzing. I had one girl came all the way from Paris, believe it or not, to see me with 6 different phobias. And in the space of 2 sessions, we cleared her phobias. And 6 weeks later, she was sending me videos back of all the things that she was able to do. So you too can help people to get rid of their phobias very quickly if you have the right understanding. So the belief or demand in a phobia is I mustn't be exposed to any situation where I become physically anxious. So it doesn't matter whether it's the bus or a train or the lift or the house or the crowd, they're all the same. The emotion is panicky, the physical symptoms that we describe, and here's where the problem lies. The commonest behavior is to avoid. Don't go to school, don't get on the bus, don't go on the motorway, don't get into the lift, don't get onto the plane. And the more I avoid, the worse it gets, because the more the amygdala is learning this danger and is remembering it. So I might, for example, in the case of a student, seek reassurance from my parents, get them to be the buffer between me and the school, etc. So what causes the physical symptoms? Here we go. Here's how we challenge it. What causes the physical symptoms? Well, we're back to the old adrenaline rush. So you again explain the role of the amygdala, adrenaline, your stress system telling the story of the leopard. Are these physical symptoms dangerous? No, exactly the same as we said before. Are any of these 4 dangers going to happen? Especially the one they're going to really worry about is lose control. So you have to explain to them that the amygdala's job is to make sure you never lose control. And that is what happens in real life. So if any of you, have any of you ever seen any of your friends or buddies running up and down a plane or a train or a bus saying, I'm just having my usual phobic reaction? It never happens. Why? Because the amygdala will always step in and make sure you do the right thing. So it's never going to happen. Are these physical symptoms uncomfortable? Yes, of course they are. They're all due to an adrenaline rush. We're back to the same pattern again. So panic attacks and phobias are 6 of one and half dozen of the other. They're first cousins. So are the behaviors like avoiding going to help you deal with it the next time? The answer is no. So I would just say to the person, well, you can spend the rest of your life on the run from these phobias, or you can turn to them and deal with them and get rid of them. So suppose, how long does an adrenaline rush last? Well, again, 5 to 8 minutes if you do nothing, but an hour, up to an hour if you try to stop them. So here's a new approach to dealing with phobias. And this will always work if the person buys in and works with you. You expose them to anything they fear. It doesn't matter whether it's the bus or the lift or the train or the car or a crowd. Whatever they're afraid of, they have to constantly, day after day after day after day, expose themselves to what they're afraid of and use the same flooding technique. And what happens is, every sort of time they use it, the amygdala gets less and less powerful in their lives and begins to reshape and relearn itself, because the amygdala can neuroplastically change. And that's in fact what actually happens. So that after a number of episodes of exposing themselves to what they're afraid of and using flooding, the amygdala learns, switches off, and that's the end of the issue. And I've had people with multiple phobias who are now doing everything completely normal. You can sort a person's phobia within around 6 to 8 weeks of day after day after day, exposing what they're afraid of and using flooding. So I'm going to move on to social anxiety now, the next big group. And you'll commonly see this in young people, maybe in their 20s, 30s. And this is where they get incredibly anxious. And some will, we've actually had an occasional situation where young people have taken their lives because of this. So this doesn't sound like a very serious thing, but can be very, very isolating for the person in question. So a person with social anxiety is terrified when they go into a group or a crowd that they will end up kind of being judged. People will see that they're anxious, judge them, and that they in turn will feel totally embarrassed. So that's the secret to social anxiety. So here's an ABC of a social anxiety situation. The trigger is going to a party. The interpretation or danger is this: what is it about going to this party that has you feeling so anxious? Now, in this case, the emotion is anxiety, it's not panic. So I'm going to become physically anxious. I'm going to get sweating or shaking or blushing or fidgety. That's what they're worried about. And the second thing they're worried about, that people will see that I'm poor at conversation. They are the key. They're the two things. People will see I'm physically anxious, and people will see that I'm poor at conversation. So if they see this, why are you worried about that? Because they will assume I'm anxious. And why are you worried about that? Because they'll judge me as weird, weak, different, to be avoided, not to be talked to. And that's, in fact, what goes on in the mind of the person, which is, of course, all wrong, but that's what's going on in their heads. So their belief is, their demand is, I mustn't be exposed to any situation where people will see I'm physically anxious, and people will judge me, and I must accept their judgment. So it's all about judgment. Their emotion is anxiety and shame. This is the other big emotion in social anxiety. They're shaking, so they're heading into the party, they're sweating, they feel they're blushing, palpitations, dry mouth, a combination of mainly of adrenaline symptoms with a little bit, of course, of mainly adrenaline symptoms. And their behavior, of course, is try and avoid the social situation, but all possible. And if they have to go, they go through this complex series of behaviors. They rehearse for maybe up to an hour as to what they're going to say, and looking themselves in the mirror. The people see I'm physically anxious. If they're in the group, they'll stay at the edge of the group. They may take alcohol. They don't start conversations. They'll monitor their faces, excess makeup. rehearse in their head what they're going to say, and when they go home, do the dreaded post-mortem. So you can imagine if every time you went out to meet a couple of people, or even meet a few people down at the cafe, and that you had to go through this every solitary time. It is a nightmare for people who have this condition. So the secret, we can get rid of social anxiety in a few sessions, but the secret is these two golden rules that I try to teach people. Social anxiety is about perception versus reality. So it's your perception of what people see physically versus the reality of what they actually see. And the second one is that people are completely self-obsessed. The whole lot of us, we're only interested in ourselves. So the perception of social anxiety, that people can see the physical symptoms of anxiety. They believe when they walk into a group that they will have a high-vis jacket on and they'll stand out. And what they fail to understand is that people can't see the physical symptoms of anxiety, and they're so self-obsessed that they not only don't see you that you're physically anxious, don't see you at all, they don't even know you're there. So people are basically totally self-obsessed. So can people see the physical signs of anxiety? No. Not only people do not see them, but they may not know you're in the room. So I give them 3 exercises to do, by the way. I give them the anxiety inspector exercise. This is where they have to go into a group and find me the anxious people, and physically anxious. So I give them this exercise for 4 weeks, and they come back and say, but sure, I couldn't find any anxious people. And so if you can't find them, well, how are they meant to find you? And then the supermarket exercise is a great exercise. We do this over here in Ireland. I get them to go into a supermarket. They have to go get the biggest trolley, go and get one single piece of fruit or vegetable, put it in the middle of the trolley and walk up and down for 5 to 10 minutes up to the supermarket. And then they have to go to the busiest queue and they have to pay for it in small change. And of course, a person with social anxiety is totally embarrassed. They think everybody will see they're physically anxious, to be judging them and photographing them, putting up on Facebook and Instagram and all that. And to their great surprise, find that after doing this exercise a few times, that nobody even knows they're in the room. Nobody cares. Nobody sees something because it's all in their own heads. And similarly, I get them to sit in a coffee shop for maybe up to 1 hour, fully dressed as we're going out for the night, having a cup of coffee. And again, they think everybody's watching them. And after an hour, they begin to realize that nobody's watching them at all. So that's a great way of teaching them that nobody sees them. So if you cannot see the symptoms of anxiety in somebody else, can they see them in you? No. So the other big problem is that the person with social anxiety believes that they are boring. I am a boring person. Why? Because I'm useless at conversation. So I get them to teach them the conversation exercise. So I ask them one simple question: what topic do people love to talk about? And the answer is, we all love to talk, not about the weather or about sport or about any, we all love to talk about ourselves. So you teach the young person the conversation exercise and they practice it for 3 months. And so what you do is the conversation exercise, you get them to constantly, if they know something about the other person, they have to ask question after question after question about that particular activity and get the other person talking about it. So it might be that you follow a particular football team and you might ask them about the football team and who's going well, and who's scored and how are they getting on in the Champions League and all. And suddenly the other person is chatting away for up to 10 minutes. If they don't know the person, 3 questions: where do you come from? What do you do? And what do you do in your spare time? And you ask question after question after question. Now, there's a critical part to this that I have to teach young people to do. They must show intense interest in the replies, and that's the secret. So you get the person to look at the person, make it very clear that you're really listening carefully to the person's conversation, and they think you're the most interesting person in the room. Incredible exercise. So I've got rid of countless number of people with social anxiety with those 2 exercises. Really, really simple. So can a person be described as weak or weird? No. Another really important thing, no. Only our behavior skills or talents can be described as such. So these, we'll come back to these unconditioned self-acceptance later. So I want to move on to general anxiety. So think about what we've learned now. We've learned that all these physical symptoms are going to present to you, and they're going to come to you and they're going to ask you, what can I do about all these things? And no amount of medication is going to get rid of any of these things. So you need skills to know how to manage them. So what about general anxiety? This is where the person comes in, they're constantly worrying. This is the health anxiety person. We'll do an example of it in a minute. This is the person who's constantly there over and over again. This week it's about my chest. Next week it's about my tummy. Next week maybe I have breast cancer. The next time I have something else. And the person also lives in this world where they're constantly worrying and catastrophizing. What will happen to children? You know, what will happen to my family, or, you know, so something terrible is going to happen in the future. This constant sense of dread. And many women will also come in feeling tired, not sleeping, nightmares, tension, headaches, irritable. And of course, you'll send it for scans and scopes and all the rest of it. And you'll fail completely to recognize that underneath all of those is actually a general anxiety. So if the person's constantly coming back to you with physical symptoms, think of general anxiety. And it's really important one. And it's a classic example of where we spend so much of our time as doctors looking for the physical cause without ever recognizing there's a psychological cause behind it. So here's a typical ABC of somebody that I would deal with. That the person gets a phone call from a friend to say that they've had a heart attack. Now the person starts to become very anxious, and their interpreted danger, oh God, maybe I too am going to get heart disease. Jesus, imagine if I start catastrophizing about it. God, it would be awful. I might end up in hospital. Maybe I'd become really ill. You know what? Maybe the stents wouldn't work, and maybe I might die. So I've gone from the phone call to dying. So my belief or demand is I must not develop heart disease. If it does, I'm a failure for letting it happen. Now, we could also put in, I must not develop any physical condition, a cancer, brain tumor, heart attack, Parkinson's, whatever. So it doesn't matter. I must not develop any serious condition that might cause me to become very ill. If it does, I'm a failure for letting it happen. So I become anxious, my physical symptoms, and here's where the physical thing comes in. I'm constantly tired, I've constantly tension headaches, I've irritable bowel, I'm not sleeping, I'm grinding my teeth at night, I'm sluggish cognitively, and they're treated as depression. And of course, they have nothing to do with depression. It's not, as we'll see later on. So my behavior is I seek reassurance, I worry and I catastrophize. I look for constant tests from my family doctor. And even if you tell them everything is fine, they'll disbelieve you. No, maybe you didn't get that right. Maybe you need to repeat it. So they'll overvisit the family doctor. They'll overvisit I've had people who've had 3 or 4 angiograms, no matter how often the cardiologist says everything is fine. No, but maybe they missed something. It's all about maybe something is going to happen. So how can we challenge the person and teach them the skills of how to manage that? So you have to explain that firstly, that all the physical symptoms they're complaining of are the symptoms of general anxiety. And you talk about the amygdala and how the right prefrontal cortex is catastrophizing and pumping out cortisol, which is giving them all these physical symptoms. So I think it's really important that the symptoms of general anxiety, you get these low-grade physical symptoms, and these are the ones that are going to catch you out. They're going to tell you, well, my heart's going a bit fast, and I'm a bit tired, and my stomach is nuts all the time, and I'm getting a bit headachy. And so I'm particularly reassured them if they get these early in the morning. The person who really panics with general anxiety is they wake up in the morning and they're shaking and sweating and stomach and knots before they've even had time to think about anything. And then they say to you, God, there must be something terribly physically wrong if I'm getting all these physical symptoms. Even before I wake up in the morning, I've had time to worry about anything. So actually what's happening there, just for your own information, is that when you're asleep, just before you wake up, you're dreaming. And during REM sleep, your amygdala and your hippocampus are particularly active. Your amygdala is 30% more active than when you're awake. And it's the one that's pumping out the adrenaline. So you wake up actually not remembering the dream, but having all these physical symptoms. And that's why you get them. So the first thing I teach a person with general anxiety is modified flooding. And that's teaching them to learn to, it's a different type of flooding because these are low grade, constantly there all day. So I teach them to treat them as background noise, to accept that they're going to be there, not to fight them, to go with the physical symptoms. And the more that you focus on something else in their life and less on the physical symptoms, the more these recede into the background. But the key part we have to do then is we have to move on to challenge the cognitive, the thinking side they're experiencing. So what happens in an ABC is that anxiety is where I make some impossible demand on myself and rate myself as a failure when I can't achieve it, plus catastrophizing. And for those who are interested, every solitary person for the rest of your lives who comes into you with physical symptoms of anxiety is doing the same thing. They're making some impossible demand of myself. You know, I must do well in my exam. I must not get a heart attack. I must get high marks. You know what I mean? I must not make a mistake. I must be perfect. It's all these impossible demands. And if I can't achieve these impossible demands, then I'm a failure as a person. And what do I do then? I catastrophize all the time about how awful it's going to be when I can't achieve these impossible demands. So it's something you can't win at. So are any of these, the question is, are any of these possible in real life? Is it possible? And the answer is no. Is there anything 100% certain in life? So what's actually happening for the person who is incredibly anxious, they're trying to control life. So is there anything that you can control in life? And the answer is absolutely not. So control is equal to 100% certainty, order, security, and perfection. So what the person is really looking for is 100% certainty. So you teach them, is there anything in life 100% certain? Can you be 100% certain that you don't get a heart attack or a stroke? So you teach them that there is always a percentage chance that you could, but that percentage chance may be extremely small. So you have to teach them to live with uncertainty. So the way I do this is I teach them the coin exercise, a fantastic exercise, which I guarantee if I give to you all, very few of you will last longer than a week. So what you have to do is name out 10 things that you love doing every day. You have to get a coin. One side of the coin is heads, the other side of the coin is tails. And for every sort of thing that you like doing, you have to toss a coin every day. And heads, you can do it, tails, you miss it, and you can't do it and repeat. So let's give you an example. You're watching something on Netflix. You get to episode 1, you have to toss a coin. Heads, I can see it. Tails, I can't watch it. Can't watch it repeat. So I move to episode 2 the following day. Maybe I'll see it, maybe I won't. So it becomes a 50-50 chance every part of my life for 4 weeks. So my life turns upside down because I'm anxious before and I'm frustrated afterwards when it doesn't happen. And this is an extraordinarily powerful exercise to teach a person to live with uncertainty. Because what are we living with at the moment in the middle of the pandemic? And I'm having to teach so many people this. We're living with uncertainty, and we can't cope with uncertainty as human beings. But we actually have to learn how to cope with uncertainty, because the secret to getting rid of anxiety is to teach us how to become resilient or adapt. And that's really the secret to this exercise. If the person is catastrophizing all the time, catastrophizing is where we're worrying about what's going to happen and the right prefrontal cortex is particularly important here, because the more we catastrophize here, the more we buzz our amygdala, the more we produce cortisol and adrenaline, and the more physical symptoms we get. So 90% of what we worry about never actually happens. So catastrophizing usually occurs in our heads in cascades. It's going on in our emotional mind. And the real problem is that our emotional mind is so much stronger than our rational mind. So I get them to do this following exercise. If I got you to visualize, what do you visualize when you visualize spilt milk or spilt water? The answer is a mess for most people. But suppose I told you I could tip it onto the table and it could be a tiny drop. What most of us do in our emotional mind is we turn the drop into a puddle, to drop into a puddle, to drop into a puddle. So what I get people to do is for 4 to 8 weeks is anytime they're catastrophizing about something, write it down and ask themselves, have they evidence that this is definitely going to happen, in which case it's a puddle, or is it only a possibility, in which case it's a drop? And after a while, it teaches them to stop catastrophizing, to begin to ask themselves the question in their head after 4 to 8 weeks, is this a drop or a puddle? Is it a drop or a puddle? Very powerful exercise if you want to reduce anxiety. And the last bit of the secret to general anxiety is, general anxiety, as we'll see with depression as well, is all about rating. People who are anxious live in the world of rating. They're constantly rating themselves. So I'm going to do a little exercise for you all. I want you to draw a line between 1 and 100. 1 means that you're crap, and 100 means that you're fantastic. So what I want you to do, I want you to rate yourself as a person between 1 and 100. So let's assume you're giving yourself a mark there, okay? I want you to rate then where other people rate you between 1 and 100. And here's a very interesting question now. You mess up as a doctor, you make a mistake with a patient. Where do you rate yourself then? And where would other people rate you? Or you're diagnosed with depression and put on medication, where would you rate yourself then? And where would other people rate you? Or somebody says you're hopeless at something, where would you rate yourself then? Or where would other people rate you? And the reality, of course, is that what do all of us do? We play the rating game, and our young people who are obsessed with social media are living in the world of rating. So if things are going well in their life, they rate themselves up, and if things are going badly, they rate themselves down. And the person who realized that this was a complete fallacy was Ellis again, the father of CBT. And he realized that the big problem was that people were rating themselves at all as human beings. So he taught people unconditional self-acceptance, and that's what I teach people. And that means that unconditional self-acceptance means I learn to accept myself as the wonderful, special, unique human being that I am, that I cannot be rated with another person. So every person listening to me is a beautiful, lovely person, totally different, totally separate, cannot be rated with another person. So the only thing that's left, as Ellis rightly pointed out, that we can actually rate in real life is our behavior, which includes our skills and talents. So what we actually do when we're struggling with our mental health is we're merging who we are with our success or failure with what we do. So I teach people to detach these things and don't rate themselves, but feel free to rate their behavior. And the reason that this is such a problem for many people, particularly people with general anxiety, is that they merge who they are, what to do, because their internal PC, their internal critic, which is formed when they're going through their childhood and adolescence, is often very hard on them and tell them you're stupid, you're a failure, you're useless, you're worthless, you're weak, you're weird, you're abnormal. So I get people to challenge on paper the bully, the PC. In other words, can I be a failure? The answer is no. Can I fail as a person? No. Can I fail at a task? Absolutely yes. So can I fail at a task at a particular moment of time? Yes. So the only failure in life is not getting back up and trying again. So the real secret is of unconditional self-acceptance, accepting that I'm not a failure, that I'm not useless, that I'm not worthless, that I'm not weak, I'm not abnormal, but I can be weak at something, fail at something, be worthless at something. So it's all about my actions. So when we separate those two from each other, people's mental health dramatically improves. And of course, if you improve people's mental health with their general anxiety, their physical symptoms come down, and suddenly you find the person is no longer looking for all these investigations and tests. So I'm going to finish with two things, PTSD and a quick word on depression. I'm going through these very quickly, and then I'm going to open up for questions. So post-traumatic stress disorders, you're going to see an awful lot of it after this pandemic. It's basically where people are exposed to a situation where they or somebody close to them either gets seriously ill or dies. And it's subsequent to that the person begins to get hyper-vigilant, all the time watching in case something like this happens again. Very often seen with people who have major accidents in war, and abuse victims, rape victims, but we see it also in serious illness and people who have serious cancers and all the rest. And often the person begins to get physical and cognitive symptoms. So they may get all the adrenaline symptoms, the shaking, the sweating, the stomach, and that. Why? Because the amygdala is hyperactive in post-traumatic stress disorder. And it's really important that they often get panic attacks and panic disorder. And unfortunately, what do? They use alcohol or tranquilizers to try to dampen down these physical symptoms and become hooked on that. And underneath that is the irrational belief, you know, I must be certain that somebody, that I or someone close to me is not exposed to anything that might cause them to be seriously ill or die. So what I'm actually doing is I'm almost up in the watchtower, looking down all the time, looking for something terrible is going to happen. And of course, I become exhausted and worn out. My stress system gets hyperwired with all these physical symptoms. So but as I explained to them, the reality is that you think that with your shining your light, like in the war, that the enemy can't come in, but meanwhile the enemy is burning underneath you a tunnel. So the reality of life is that we can't control, here we go again, there's no control over anything in life. So I give them the coin exercise and teach them that in real life, they have to get down off the watchtower and dampen down a lot of their hypervigilance. And that's how we manage it. Depression, I just want to finish because I want to give time to, this will be one of my areas of expertise, and I've been very fortunate. I've worked with some of the world leaders for about 5 years in terms of cognition and depression. So what is depression? Well, depression is an illness. It's not an emotion. An emotion is, we all get depressed, the emotion, we're all a bit down from time to time, but depression, the illness, it comes in bouts, usually lasting 6 to 9 months. 50% of them, really want to make this point, will occur for the first time between 15 and 25. So 25% between 15 and 18, and 25% between 18 and 25. So 50%, 1 in 2 of all people with depression represent for the first time between the age of 15 and 25 and are regularly missed. I think it's important that it's commonly misdiagnosed as general anxiety. People don't realize that it's coming in a bout. There is a thing then called late onset depression, which occurs in the 50 plus group, which occurs through vascular changes in the brain and things that are happening to the person at that stage in their life. I think it's important that it's physical, psychological, and cognitive illness. So what do we mean by this physical illness? Really important with men, always explain to men that depression is a physical illness. You get tiredness, you get low sex drive, your motivation goes down, your difficulty eating, you have no interest in anything, you have no enjoyment in anything. Physically, it's associated, there's a greater incidence of heart disease, there's a greater incidence of diabetes. So it is a huge activation of your immune system, there's huge activation of your stress system. So it's a very, very physical condition. Psychologically, we know that you can feel very down, constantly down over and over, every day for maybe 3 months, 6 months, 9 months. Very often the person loses and it has anhedonia, has no interest, no enjoyment of life, feels very low about themselves, feels very negative about themselves. They can see no hope for themselves or the future. Really, really important that cognitively, this would be where I would be really most interested in, that cognitively 95% of people will have some cognitive difficulties. And there are 4 key factors in cognition. They are your memory, your attention or concentration, your psychomotor speed, that's the speed at which your body obeys your brain, and your executive function, which is how you problem solve. So those 4 go crashing down in depression. So if a person is truly depressed, they will really struggle in all 4 of those areas. And if a person is saying, no, I'm having absolutely no problem with those, then relook at the diagnosis, because it's highly unlikely that it's depression. So the person will really, really be struggling because their cold cognition will be down with these, and their hot cognition in terms of I'm worthless, I'm a failure, I'm useless, I'm weak, etc., will be really buzzing. So, and the last thing is, of course, they get suicide thoughts. Suicide ideation is really common. And the most important question is to ask, have you any plans? Because that will tell you how serious those suicide thoughts are. The neuroscience behind it is really quite interesting for those who are really interested. I think the amygdala is overactive, the insula is overactive, the hippocampus or memory box is underactive. There's increased activation of your stress system, particularly pro-inflammatory cytokinins, high glucocortisol levels, reduced serotonin levels, or not levels, reduced serotonin activity, sometimes reduced noradrenaline activity or dopamine activity, and your default mode, which is the area. The default mode is what your brain does when you're not doing something. It goes into this almost kind of a different world where you're daydreaming, and of course we get all these ruminations in depression. So there was the assumption that the default mode would be overactive, but we now understand that it's not overactive, but there is a hyperactivity of the amygdala when it's triggered by the default mode. So that's what causes all the ruminations and the low mood and all the rest of it. So really important to know all those. Your left dorsal prefrontal cortex is often less active, and so on and so on. If people want to ask more about that, they can. So treatment, as we all know, the treatment is drug treatment to get your mood back up again, lifestyle changes, exercise, stop alcohol, watch sleep, watch stress, etc. And the cognitive behavior is, remember, you never do CBT or any kind of therapy with somebody until their cognition is back up to normal. That's the biggest mistake in the whole of mental health, where they're trying to treat people with depression with CBT or lifestyle changes or some kind of talk therapy, particularly when really they're not capable of even retaining the information you're trying to get. So there's no point in dealing with all these physical symptoms until their cognition is kind of coming back up to normal. I'm going to give you the following because I think it might be very helpful for you. drharrybarry.com has videos, and a lot of my colleagues over here in Ireland, what they do is if they have somebody with panic attacks or phobias or general anxiety, they get them to look at these videos first. For example, so before they do an ABC on the panic attack or the phobia or the social anxiety, to get them to look at my videos first, maybe read my Anxiety and Panic, which is the book, which at the back of that book explains all the neuroscience for those who are really interested in it. And then come into them and then do an ABC and then go through it. So in other words, I'll do a lot of the hard work for you. Do you know what I mean? If you use my videos and books, it'll make it a lot easier for you when you go, because the person will be thinking like this. Other books, Flagging the Therapy, Depression, a Practical Guide, really good for depression. Emotional Resilience, Self-Acceptance, Emotion Healing, Embracing Change. I think I'm on my 11th book at the moment, I'm writing at the moment. So, but Anxiety and Panic is particularly useful, I think, for many, many people. And I would really strongly advise to go and look at the videos. Like the video on panic attacks has been seen by over 1/3 people. And I've one in America, which has been seen by over 1 million people. Actually, I think it's 1.25 million or something like that at this stage. So I get contacted from all over the place in relation to this. So hopefully you found that of interest and of some help. And I'm going to pass it over now to Rafida or etc. For any questions that you might ask. And you can ask me, by the way, any questions in the area of mental health, because this is my expertise area. Can you hear me there?
Okay, so doctors, please, if you have any question, you can write that down. Yes, Dr. Harry, we have some questions right here.
Great.
Okay, so we have, one of them is asking, she is saying, please, can you explain the coin exercise?
Right, okay, I'll explain this one in greater detail to you now. So I want you to list off 10 items. Let's go through the kind of items I'm talking about. I might like going for a walk every day. I might like doing yoga. I might like doing Pilates. I might like reading. I might like listening to particular music. I might like watching something on Netflix. I might like watching some documentaries or some sports. I'm back here in Ireland, I might like taking a glass of wine with my meal. I might, so things that I really like, I might like going out with my partner for a meal. Do you know what I mean? So things that I really like doing all during that 4 weeks. And every solitary time I want to do these, let's go through them. I tossed a coin. Suppose I want to go for a walk. Heads, I can walk as fast as I like. Tails, I have to walk like a snail. Heads, I can listen to music I like. Tails, I have to listen to music I hate for the day. Heads, I cook what I want. Tails, I cook something I hate and I have to eat it. Heads, I can read my book. Tails, I can't. Heads, I go out with my partner. We both get ready. We're walking out the door, and then we toss the coin. I go, look at this one. Heads, I can go. Tails, I can't. And of course, it's all about teaching me that the reason that I look for control in big things is because I think I control my everyday life. But of course, if I begin to realize that, hey, it's a 50-50 chance all the time as to whether I can do this or not, I begin to realize after a while that I can learn to adjust. I can learn to adapt. And the more I learn to adjust and adapt to the uncertainty of life, the less anxious I go, the less anxious I become, because I no longer demand that something must happen. I begin to realize, hey, this is a total waste of time, because it's like the toss of a coin. Sometimes it'll happen, sometimes it won't. But the chances are much higher in most things in life that it'll go your way than it will in the coin exercise. So brilliant exercise.
Thank you so much, Doctor. Let's take Saleh Al-Harbi. Dr. Saleh, if you want to ask your question, if you want to unmute yourself, please.
Yes.
Yeah. Hello, Dr. Harry. Thank you for your great presentation. My question is related to anxiety somatic symptoms. Any tips to how to deal with the patient after delay of diagnosis, years of reinforcing the symptoms and doing investigation? If you see the patient at late stage, how to deal with this fixation that there is something organic? you didn't pick the patient from the early start?
Yes, I think these are very difficult patients, Salah, because you know, what you're hoping as much as you can to get these earlier, do you know what I mean, so that you can head them off so that they don't go down this road. But I think all that you can do really is by doing some ABCs with them, do you know what I mean, by getting them to see, you know, what, you know, you've got to find out what their danger is. Like, is there a danger that they're going to die? That's the commonest one, you know. So it's almost become like a PTSD. I must be absolutely certain that I'm not exposed to any condition that might cause me to become seriously ill or die. So a very good question that I often ask them is, what is it about dying you're afraid of? It's a very interesting question. And they will say to you, well, I'm worried about the manner of my death, or I'm worried about leaving my children behind, or I'm worried that it'll be very painful, or I'll be worried that I don't believe in another life and that this is all there is, or I'm very anxious that when I die, I will go to somewhere and it won't be where I want to go. So, you know, very important to find out what is it about dying that people are worried about. But I think it's obviously, you know, the big problem with these for the doctor is that the trouble with this is if I present 20 or 30 times with symptoms that are of no import, it's the 31st time, unfortunately, there might be something that might be a problem. Do you know what I mean? There might be something that might be an issue. So you have to keep your eyes open all the time. Is there something different about this other than what we've had before? But other than that, try and do an ABC with them. Try and get them to do the coin exercise. Try and say to them, look, you know, it's you know, your issues are more to do with how you're thinking about these illnesses rather than any particular illnesses. And if they're not prepared to accept that, then I think, you know, there's very little you can do. People will only change their behavior when the cost gets too high. That's a great line. Maybe get them in terms of, well, you know, is this helping you in your life? Is this irrational belief helping you in your life? Are you feeling happier in your life? You know, are you spending an awful lot of time and energy and effort worrying about something that, yeah, there is no point in worrying about? So I find I get people like that by challenging them, you know, what's in it for you? Try and get them to always say, what's in it for you, to look at it a different way. That might help.
Amazing. Okay, Dr. Wafa, do you have any questions? I can see your hand.
Yes, yes. Thank you
Please
so much for very interesting and informative lecture, Dr. Harry. I have a question. People, they came with the in depression and anxiety, and they have low mood, and they decreased cognition, yes, and decreased concentration. But after a while, after 3 to 4 months, after the therapy, we have start CBT and the SSRIs, like the drug, still they complain the same thing. Their mood has improved, anxiety has gone, but they say still the cognition and the concentration is decreased, reduced. It is not back to the normal. Please, how we can help this? I have a lot of patients like this.
Yes, this is a great question, because we now understand, firstly, it's really important to diagnose that condition was more likely to have been depression rather than anxiety, because the person had persistent low mood. So a very good way of always start by, is the person generally anxious? Do they complain of that they normally are anxious? They normally are worriers. They're normally catastrophizers. And the person will tell you, yeah, I'm like that all the time. So that means they have a background of general anxiety. But if they say to you, you know, no, I don't normally worry a lot of the time, but I find my mood falling a bit, and then I started to get very anxious, then it's more the anxiety is related to the depression rather than the other way around. So the second part of your question, I think, was really, really important, that we know that many people, even when their mood begins to lift with say SSRIs or whatever like that, that they still retain some cognitive difficulties. And this is a huge problem, because depending on the person and depending on the amount of cognitive difficulties, if it's very significant, then the chances are their depression is not really probably fully treated. You want to be very careful that sometimes the person would say, okay, my mood has gone up a little bit, but I'm still exhausted. I'm still not sleeping. I'm still very having a lot of negative thoughts. My cognition is still very poor. Well, I would often suggest that maybe it might be a good idea to have a specialist look at their mood and say, are they genuinely fully treated? Because sometimes they're only partially treated, and that's the one you really have to watch for. Just be careful that their depression is fully lifted. CBT will be very good for the anxiety part. It's helpful to help with what we call hot cognitions, but it's useless from the point of view of cold cognition. It will not help with cold cognitive difficulties. That, in my experience, has to really be done more with medication. And lifestyle as well. Make sure the person is exercising, is not drinking too much, not under too much stress. But if all those things are being looked at and they're getting enough sleep, then, you know, it probably is their medication that you may need to look at. But we do have to accept that there will be a percentage of people who will have low-grade cognitive difficulties even long after their mood is really kind of back to normal. It's, by the way, for your own information, this is one of the most important causes of absenteeism and particularly presenteeism in the workplace, because many people go back to work, they say their mood is all right, and they're probably better back at work most of the time, but they're not fully there cognitively. They're just slower. They're all those four things I talked about: their concentration, attention, psychomotor speed, all that's down. So it's something to be aware of and to watch for. So I hope that was of some help to you.
Thank you, Dr. Harry. So here is another question by Rawan, Dr. Rawan Malki. She's asking, we should not start CBT and talking therapy easily because of the low cognition, right? She's asking.
Yes, because if you're, think about it like this. This has happened to me. I'll give you a very good example of this, where this man came to me, his wife was a nurse and she asked me to see him. And he'd been quite depressed for quite a period of time. And he asked me, well, you know, how are we going to manage this? He accepted the diagnosis when I explained it to him. And I said to him, well, we're going to use some medication and then we're going to do a little bit of CBT after that, you know, and we made some lifestyle changes. So he said to me, well, could you explain to me what the CBT would be all about? So I went very gently into what I would be doing. But I said to him, we won't be starting this now until I'm happy that you're ready for this. So I was talking to his wife subsequently, and she said, you know, he really enjoyed the chat with you and was delighted with. The only problem was when I asked him, well, what would the CBT involve? He couldn't remember a single word I said. Now, I think that maybe more, that little story is a real lesson to us all, that we all assume that the person is absorbing all the information, and sometimes cognitive, they're only getting maybe 10% of the information. So if you are trying to do talk therapy or particularly CBT, they will only look at the negative. That's the difficulty. The amygdala is very overactive. The amygdala is our negative part of our brain. So it's pumping out all this negative stuff. So what actually happens is that our cognition is not grasping what the CBT therapist is trying to get the person to do, or if it's to do with even relationship counseling, you know, they'll be taking the worst out of it all the time. Whereas if their cognition improves and they're feeling better and they're thinking better, then they're ready to take on board the CBT. That would be my experience.
Okay. She's also asking and saying, how can we elevate the cognition?
How can we lift it? Is that the question?
It says elevate. E-L-E-V-A-T-E.
Elevate,
right,
is it?
Rawan?
Would it be how to elevate?
Yeah, elevate.
Yes. Well,
yes,
I think it's a really good question. Yeah, I think here's a few interesting tidbits, really. My experience is that a lot of people who are struggling with really poor cognition, you have to be careful that their mood is not fully treated, or that they're on a medication which is hampering their For example, we know that mirtazapine is a really good product for mood, but it puts on weight, and unfortunately for some people it will worsen their cognition. Some of the atypical antipsychotics will actually dampen down your cognition. So you may actually be trying to use something to help the person and actually making their cognition worse. So be very careful of that, especially any kind of tranquilizers are disaster from the point of view of cognition. Also make sure the person is getting enough sleep, because if they're not getting enough sleep, sleep is when our brain kind of recovers. So if you're not getting enough sleep, your cognition will be affected. So always try, and sometimes I find a change of antidepressant, maybe something more on the lines of duloxetine or Brintellix, or one of these more cognitively enhancing antidepressants might be of help if the person is really struggling. Sometimes ask a specialist, do you know what I mean, if you feel that they're really, really struggling with this, because it can be terribly distressing for the person if they're cognitively really struggling all the time. It's like they're working at half speed all the time. So look for, as I said, make sure that they're getting enough sleep, make sure they're not taking alcohol, watch and look at their medication, and even review their treatment of their depression itself, and sometimes even get a specialist assessment. Those things might be of help.
Thank you so much, Dr. Harry. Here is Fajr. I think she raised her hand. Fajr, please, if you can unmute yourself, you can speak up. Dr.
Yeah,
Fajr?
Hello, Farah, we can't hear you. We can't hear you well.
Dr. Fajr, we can't hear you. Actually, I think you are having a connection problem.
Thank you very much, Doctor, for this informative, reachable presentation. Just a kind of a hint, hello?
Yes. No,
now you can hear me?
Yeah, just about fair, just about.
Hello?
Yeah.
It's okay?
yes.
Hello?
Yeah, that's good.
Yes, go ahead.
Yes. Thank you very much. Doctor, actually, yeah, just one query and one question. Yes, prevalence, if you have a kind of updated prevalence of increasing of anxiety disorder or cases after the COVID. After COVID-19, rushings of the patient coming with an anxiety, even if the patient having anxiety before it's getting, just give us guidelines or a kind of basic things that we can dealing with these cases that they don't want to rush on medication. They want a kind of, some ventilation or some CPT, I don't know. Just we want to deal a kind of highlightings for this. Okay, thank you very much.
Well, here's a wonderful line that you should all write down, and I use this all the time here in Ireland. It is the situation which is abnormal, not me. It is the situation which is abnormal, not me. What we mean by that is that it is normal and natural for somebody to be anxious during a COVID pandemic. In other words, if let's face it, nobody here has not had some anxiety about picking up this virus or passing it on to somebody we love, or even the concern that we might get it in the future. So it's natural that people would be anxious. That's what I would call a normal anxiety reaction. That's not where the person is worrying away about something that might never happen. This is where they're worrying away about something they have experienced. So I think it's the first thing is to normalize and say, look, it's normal to feel like that. It's okay to feel like that. There's, so stop normalizing it. But just if you were to say to them that if they become hyper vigilant, that they're almost living their lives so carefully that they're not living at all, well, then I think you have to give them the idea of the watchtower. Say to them, look, we could be up there in the watchtower being absolutely certain that we're never going to get COVID. But can we be absolutely certain that in the middle of that we don't develop a cancer, or that our loved one close to us doesn't get very ill? Of course we can't. So we can't control life. So a very good thing to do is give them the coin exercise to show them that you can't control anything in life. That is all out of our control. But tell her not to be worried or not to be concerned if they're feeling anxious during this time, because it is normal and natural to be like that. And I think if we could all talk about it and normalize it, and as we don't take it too seriously, and the idea of treating somebody with medication for a normal anxiety reaction, that is crazy. So obviously you would say there's no need whatsoever to do this. So maybe give them a simple coin exercise, maybe even do a quick ABC on what are they actually anxious about, what do they think is going to happen. And it'll always be about my danger is, I must be certain that I don't get another serious episode, or somebody close to me doesn't get a serious episode. And I think the answer back is, well, can we really control all of that? No matter what we do, we can do our best. We can take all the guidelines, we can get our boosters, but can we absolutely 100% guarantee that we won't get it? The answer, of course, is no. So we have to learn to live with this. It's part of adapting to the pandemic.
All right, thank you, doctor. All right, so we're gonna have 2 more questions. I'm so sorry if we're making you tired, actually.
No.
Hanan is saying, thank you for your amazing lecture, but I want to say that sometimes CBT is not available for everyone. So is there any other way to get it? Maybe an application or a website that you would recommend to have sessions online? So
I would recommend, to be honest, CBT is not available in many areas. It's not even easily available in Ireland, but CBM is available to us all. Because cognitive behavioral methods are simply just simple understandings of how CBT works. We don't need major CBT interventions most of the time, apart from people who are really in difficulties. For the vast majority of people, we don't. So I would strongly, like, all of my books are explained, like Flagging the Therapy, Anxiety and Panic, Emotional Resilience. They all explain CBT and how to do it. And you can apply the very simple CBM techniques by reading some of these books yourself. And very quickly you'd see, that's how it's done. And it's actually very, very simple, because in reality, mental health is very simple. It's us that's making it complicated. We want to make it very complicated, where in fact, people are very intelligent and people respond quickly to very simple, practical techniques. And I think I've given you a good lot of them there this evening. Look at my videos, read some of my books, and I think you yourself will very quickly feel, I would feel quite competent in doing that. And I'm teaching, for example, guidance counselors here in Ireland how to get to deal with the children who are anxious. I've given a talk to all our GPs in Ireland, trying to get them to deal with anxiety in a very similar kind of way to the way we went today. So to me, this is about simplifying it, not making it a big thing. It's a simple ideas. Like getting a person to do the coin exercise is not rocket science. Getting a person to do the supermarket exercise or the anxiety inspector, they're not rocket science. Flooding is not rocket science. And yet you'd be astonished how countless people that I would have assisted over the years have responded so well to these very simple ideas. And I think you too could easily learn these techniques and bring them into your practice. And my goodness, you will find the patients will respond hugely to them. So that would be my advice.
Thank you, doctor. So the last question says here, Dr. Hassan Arufai, he's saying, thank you, doctor. Thank you for your great presentation, doctor. How about somatic symptom disorder and illness and anxiety disorder? Can we use the same ABC?
You see, I kind of don't, I find the word somatic is very vague. I mean, it's simply the bodily responses to something that's going on in our mind, but it's kind of like almost separating our brain from our body and our mind, which we can't really do because we're all one. So anything that affects our mind will affect our brain, will affect our body. So in some senses, For example, let me give you a really good example of a somatic disorder. Have you all come across the term of chronic pain syndrome? Well, a chronic pain syndrome is a very interesting, here we are, a very typical somatic example here, where actually what happens is, suppose I have a problem in my back and I have a disc problem for a while and I begin to get chronic pain there. And after a while, even though the cause of that back pain has been managed and treated, I still find I'm getting this chronic pain there all the time. Well, what happens in some cases is that the brain itself creates a loop. The brain begins to, a part of the brain begins to enlarge as it begins to focus only on this part of the body. So what actually starts to happen is the source of the pain is actually now no longer down in my back. It's actually coming from my brain, but it's been referred back down to my body. So I start to feel it there. So increasingly people are beginning to see that a lot of these somatic symptoms have their origins in the brain. And the insula, for example, is the place where we feel pain. And the anterior insula, particularly on the right side, is where we feel emotional pain. So, for example, we know that people who, when they're depressed, feel pain a lot more. And of course, that makes sense because their insula, their anterior insula is actually overactive. And that's where we actually interpret pain. So we really have to do away with this idea of, you know, trying to kind of almost divide them all up. And that's where we're running into trouble all the time. Like the trouble with a panic attack, for example, is all these physical symptoms, which actually have their origins really psychologically in some ways, but are very visceral. But if we start abnormalizing the physical symptoms, then we get a panic attack or we get a phobia. Or if we believe that people can see the physical signs of anxiety, well, all of these things are the bodily manifestations of just our emotions. So there's a massive link between our emotions and our physical symptoms. So an awful lot of these conditions, in my opinion, now what you do get sometimes is you can get certain conditions where the normal, what we call automatic or internal physiological processes, actually we start almost become conscious. So instead of something being unconscious, it nearly becomes conscious. So we start to become oversensitive. A certain number of people are oversensitive to physical symptoms. And for example, one body of opinion was that phobias were simply an almost overemphasis on somatic symptoms. But I've tried to simplify all that and get rid of all this stuff, because if you make it very complicated, then you've made it really complicated for the person. If on the other hand, you teach the person with a phobia, exposure and flooding, then you clear up their problem without them having to go through any of this stuff. So I'm in favor of simplifying, simplifying, simplifying. And great family doctors are those who a good empathy bond with their patient and is able to kind of sit down with them and work through some of these issues with them in a simple, give them simple techniques. And I guarantee you, if you can work with some of your patients, you'll be friends for life with them, because they will never forget the person who helps them in these areas, because everybody else is saying there's nothing wrong with you. There's no physical problem. We can't pick up a heart problem or a diabetic problem, or, you know, they're all being told you're normal. There's nothing wrong with you. And they're feeling all these physical symptoms. So, and they're waiting for somebody to explain them. So by validating their emotions, validating the physical symptoms, and explaining what they are or why they're getting them, and give them simple techniques to deal with them, you manage so many of these conditions. Because most of what you will see in general practice or in primary care and family medicine is exactly what we talked about today. These are the common ones. And this is what you would see over and over and over again. You will have some very rare conditions, but to be honest, they are like that, rare. And that's not what you should be focusing on. Focus on the things you're going to see every day of the week. And I guarantee you, you will see these conditions over and over and over again. You may not initially recognize them, For example, the person who comes into you initially with health anxiety, you may not realize it's a health anxiety, and you'll be busy doing scopes and cardiographs, and then after a while you begin to realize, hey, you know, this person is coming in with a different problem every time, and we're investigating them and there's nothing there. But of course, now you have to start coming back a little bit and say to the person, look, you know, would you mind if I just asked you a few questions? You know, are you a bit of a worrier? Are you a perfectionist? Do you do a lot of rating yourself? Do you do a lot of catastrophizing? And you'll very quickly find that this is a person who's general anxiety. And then you say, well, look, maybe we should try handling this in a different way. And off you go. So that would be my advice.
Amazing. Okay, I'm so sorry, doctor, but this is the last question, hopefully. Okay, so it's gonna be, what is the relation, Dr. Ali Al-Khalif is asking, what is the relation between insight and conducting a CBT or CPM? Because some conditions with a poor insight might not respond or accept CBT.
Yeah, I think if the person has very poor insight, well, I think you have to ask yourself, you know, what's the basis of that lack of insight? Is it that they don't want to change? We haven't done it tonight, but I spend a lot of time over here explaining to people about the world of frustration. Frustration is called low frustration tolerance, and it is the alter ego of anxiety. So you'll have lots of people who are worriers and catastrophize, but the person with frustration is the person who doesn't want to change. I want everyone else to change, but I don't want to change myself. So sometimes when you hit a person who doesn't want to change, you think that CBT doesn't work, but of course it works really well, but you just have to use a different technique. So if you're interested, here's 3 questions for a person who's, a person with frustration is the person, I want long-term gain, but I don't want short-term pain. I want the situation to change, but don't want to change myself. So if you come across that in your life, it's very well done, by the way, in emotion resilience, and it's also done in embracing change. Those 2 books, Emotion Resilience, Embracing Change. Frustration is the greatest hidden emotion never discussed in mental health. It causes huge problems, and it causes a lot of physical symptoms. It causes cardiac arrhythmias, it causes high blood pressure. Sometimes it can even be a trigger behind strokes. So we kind of ignore frustration. We all talk about anxiety all the time, but we never want to talk about frustration. So remember, the person with frustration is all the time wanting everybody else to change, is bad-tempered, is short with people, is irritable with people, gives out to people, and is very difficult to live with. Why? Because they see the world as really a certain way, and it has to be like that. We're back to these irrational beliefs. The world must change to suit me. Good luck with that. So here's 3 questions that I get people to do for 3 months. I'll just give you these questions and maybe we'll stop then. 3 questions are, number 1, what is my long-term goal in this particular situation? If I'm frustrated about something, what is my long-term goal in this situation? Number 2, what short-term pain am I trying to avoid in this situation? And number 3, what changes in my thinking and behavior do I need to make to achieve my objective in this situation? If I could answer those 3 questions constantly, I had a very successful businessman who came to me. He thought he was anxious, but of course he wasn't. He was struggling with frustration. His life was a mess. His work life was a mess. His family life was a mess. So I got him to do this exercise for 3 months, answering those 3 questions every time he became frustrated. 3 months later, he came back to me and he said, my whole life is completely different. My family life is working well again. My home life is good. My work life is good. And I'm not stressed, and I'm happy in my life again. In other words, he realized that he had to change. So when he started changing his thinking and changing his behavior, using simple CBT techniques like the one I just gave you a minute ago, that was the end of his problem. So don't think that this is high-powered. You know, you can make it as high-powered as you want to, or you can make it as simple as you want to. If you do a good bit of reading through some of the books that I've done there, everything that you need to know is there. And, you know, people have been helped right around the world with these books, so it might be very useful for you. And don't be afraid to get your patients to look up the website, get the books, and do the work for you. do a bit of reading themselves, and that might help you in your career. Okay.
Amazing. Thank you, Dr. Harry. Thank you all for joining this evening. It has been really an interesting session, actually. And thank you so much from all of us to Dr. Berry, actually. We really appreciate this excellent session, Doctor.
Not at all. It was an absolute
no more
pleasure to meet
questions.
you all.
Thank you, Doctor.
Okay.
All right.
Okay.
So,
bye now.
bye for now. Thank you so much, Doctor.
Bye
Bye.
now. Take care of yourselves now.
Thank you.